Hi guys, welcome to my channel. This topic is gonna be like, I'm sure like for the average person it might be really hard to understand. It's like some deep stuff but we're gonna talk about the heart today. I really need to like make it as simple as possible for you guys, or try to. First, I'm talking about the heart, right? What could go wrong with your heart? You could have a problem with the valves of your heart, right? You could have a problem with the ventricles of your heart or the chambers of your heart. You could have a problem with electrical activity in your heart, and electrical activity in your heart plays a very big role in the function of your heart. And I was gonna go deep into the electrical activity in the heart like today for this video. So let's get to it. Okay. Let me try to make it as easy as possible. Oh my god, I think we need to know like basic vocabulary first. Okay, so first we need to know the nodes of the heart, and we need to just understand electrical activity in the heart in general. Electrical activity in your heart is sent, or is like, in order for your heart to pace and pump blood, it has certain things in your heart called nodes, right? And those nodes are what regularly function to pace your heart and to kind of like send signals for your heart to constrict, and push blood to your body, right? But things could go wrong, right? So the nodes that you need to know, anatomy, is the SA node. You need to know about the SA node, which is in the right atrium. The AV node, which is not in the ventricle but like between the atrium and the ventricle. Then you've got the bundle of hairs going down. Then you've got the Purkinje fibers. Okay, so that's how your blood kind of flows through. The thing to understand about the AV node is that the AV node will slow the heart down, as in when the SA node fires a signal, it will kind of like stop for your, if you know, your ventricles, which are the chambers of your heart, to fill. Okay, so we know those are the basic like normal things that are supposed to happen in your heart in order for your heart to like send signals, electrical activity for your heart to pump effectively, or to send blood to the rest of your body, also called perfusion. Okay. So but then your heart, in contrast to your muscles, have like something called automaticity, which is like the its way of also generating its own electrical activity in the heart. And automaticity, you could have automaticity happen in the atrium or in the ventricle. Okay, so that being said, we just need to understand, first of all, when it comes to the nodes of the heart, like what is a normal pacing. It starts with the SA node. As we know, our normal heart rate is like between 60 to 100, which is fired by the SA node, right? Which is why the SA node is called the pacemaker of the heart. But then you've got the I wish I had it. I feel like a picture will make it so much easier. Oh my god, now I feel like I need a picture of a heart. Okay, let's just explain it first. But it's so hard to explain, I guess, without a picture. But then you've got the AV node. The AV node sends impulse between 40 to 60 beats per minute. Then you've got the bundle of his and the Purkinje fibers, which will send between 20 to 40 beats per minute. Good. So we've got a normal beat. So, and the way it works is like, if the SA node doesn't work, the AV node takes over. If the AV node doesn't work, the Purkinje fibers takes over. Like I said before, the heart can also generate its own electrical activity called automaticity. And with automaticity, these are not really regular or good rhythms to have. So automaticity, so it can generate impulse in the atrium, in the atria, not the SA node, or in the ventricles. And some of what they call dysrhythmias, because of these, it can lead to dysrhythmias. And yeah, we'll talk about those. So now that we know um, the normal aspect of the heart, what could go wrong with either the SA node, the AV node, or the fact that there's automaticity both in the atrium and the ventricle. First, in order to generate all of this, we use something called an ECG, and the ECG is very diagnostic for all of this dysrhythmias, for whether you had an MI or electrolyte imbalance. What else? That's really all I can think of right now. Yeah, and heart rate and all of that. But then nurses at a hospital would use telemetry, but it's not necessarily diagnostic, or it's not diagnostic, not necessarily. Okay, good. So now let's see what could go wrong with the SA node, right? Kind of like dysrhythmias or rhythms that are not normal in the SA node, the normal pacemaker of the heart. We could have something called sinus brady, which is when your heart would beat between 60 to 100 beats per minute, which is our normal heart rate. I mean that is normal sinus. Sinus brady will beat below 60 beats per minute, like bradycardia. Sinus tachy, where the sinus node will beat above 100 beats per minute. Or sinus arrhythmia, where the rhythm is just not regular but everything else is regular. But then you want to say, okay, what is wrong with that? Like, why would it be a problem if my nodes don't signal properly? If they don't signal properly, then you don't get enough perfusion to your heart. Like, for example, with the SA node bradycardia, you'll become cool. You're not getting enough blood flow to your body. With sinus tachy, it's just too much output. But I mean, it's not necessarily like an emergency or something you need to worry about, but like it could cause, if it's fibrillating too much really, or if it's like pushing too much, it could lead to like thrombus or a clot, which we'll go into as a complication of a general we'll get there. So that is that. And then in the AV node, which is like between the atrium and the ventricles, you could have things called AV blocks. So basically a blockage of impulse to the AV node. And there's degree type 1, where the contraction between the atrium and the ventricle is very slow. It's just very slow, that's it. So you have a lengthening, something called a lengthened PR interval. And you can have AV block type 2, 1, also called Winky block or Mohs beats 1. With this one, you have a lengthening time between the contraction of the atrium and the ventricle is just lengthening. And then there'll be a drop in QRS, as in contractions of the ventricles will just drop. That is okay. It's not necessarily an emergency, but we want to take care of that. We want to really take care of that. Or you could have AV block type 2 or Mohs beats 2. This one is an emergency. With this, like, there's no pattern to the PR. It's called PR interval, the contraction between the P to the contraction of the atrium to the ventricles. It can be long, it can be short, but there's a widened QRS. Basically, the contraction to the ventricles is very slow. And if the contraction to the ventricles is very slow, there's not enough blood going to the rest of the body. You see where that goes. So with this, we treat it as an emergency. We'll do something called cardioversion. We'll give, because it's Brady or it's slow heart rate. It's usually slow heart rate because it's a blockage of impulse. We're going to give atropine. We're going to give epinephrine. That's all I can think of right now. Okay. So AV block type 3 is even worse because there's no coordination, or there's no relationship between the contraction of the atrium and the contraction of the ventricles. And I know it's really hard to understand because you need to really know like the normal electrical activity, and I didn't get into that. Maybe I'll make a video on just a normal impulse and what it means, but for now we'll stick into this. So that's the AV block. You could also have like automaticity. I don't know how long I am into this. And with automaticity, you could have a problem in the atrium, and in the atrium you can have AFib, which is atrial fibrillation, which can lead to a clot. You could have a flutter, which could also lead to a clot. But a flutter can lead to a clot. We'll kind of slow it down with some calcium channel blockers. AFib will give again, I think we'll give calcium channel blockers. So calcium beta blockers, calcium channel blockers for AFib and stuff. And we can also have PAC, or premature atrial contractions. We'll just slow it down with some calcium or beta blockers. We can also have an SVT, sinus, is it, oh my god, I just forgot what SVT is, I'm sorry. SVT, which is I don't think it's not necessarily in the ventricle, but it's above the ventricle, supraventricular tachycardia. So we'll give like adenosine for it. But then you could also have problems or that automaticity going on in the ventricles, where you have ventricular tachycardia, where the ventricles is just like kind of doing this too much, like this. Or you could have VFib, where the ventricles is just like fibrillating. Is really bad because it can lead to a clot, and you're not getting effective blood to the rest of the body. And that's how we're going to treat that with something called cardioversion or defibrillation. You could also have PVC treated with lidocaine. And those PVCs are not, they're not necessarily emergent, and we'll treat that with lidocaine. Okay. That was a lot to digest. Okay. So with sinus brady, though, they could also do something called artificial pacers. Like I said, sinus brady, sinus tachy, all those things. So they can actually put an artificial pacemaker to help your heart pace better. But then there are complications to this, like it could lead to, you could have an infection in there, you could bleed from it, and it could kind of like move or dislocation. So after the person gets out of surgery, after that implantation of the pacemaker, you want to tell them not to move their arm for a certain period of time. And I don't know if I can go over that in this video, but pretty much 24 hours to 48 hours, they can't move their hand, and they cannot do any contact sports for 2 months, 2 weeks. They cannot do any range of motion. And with that pacemaker in after surgery. And also, if you have that pacemaker, you cannot, at the airport, you need to put on a bracelet and tell them not to use that magnetic thing when they check if you have any gun on you, because you have a metal in there, and it's not good. It's gonna mess up your your pacemaker. But there are many types of pacemakers, though. The one I was talking about is the permanent. There's the temporary one used during surgery, where they'll put it outside the heart, which is called epicardial or endocardial inside the heart. They could also do transcutaneous, which is the one that they use. They will use this for like AV block type 3 or AV block type 2 to kind of reset the heart, and it's important to know where it is. All right, so in order to put the pads, and I'm going to get into like that defibrillation versus cardioversion. In order to do defibrillation, obviously you need to put the pads on, and you can, in order to put the pads on, usually to put it like on the right side of the patient, above above your breast, or the left side below your breast, below the nipple there. And you want to make sure that it's dry, because it's electricity, no hair, use an electric razor. Make sure that it's in good contact with the skin, else the electrical impulse is not gonna go. Okay, so that is that. And so now talking about VTAC and VFib. So if the patient has no pulse, you're going to do something called defibrillation. Defibrillation is pretty much like a shock that they give to you, and it will just reset the electrical. It's supposed to reset the electrical impulse in your heart, and we do that after we've given, let's say, a medication called amiodarone, and if it didn't work. But if it's like emergent, you're at a hospital and you see no pulse, you're gonna defibrillate the patient. And for this one, it doesn't matter exactly where you do the shock. You just put it on the machine, like defibrillate, and it will shock, and then you do your CPR. Whereas cardioversion is similar to defibrillation, but it's elective, as in you can schedule a time to come for cardioversion. And before you come there, you're gonna, since it's elective, no food for 4 hours, and you're gonna come in there. They're gonna put the pad on you and shock you with the cardioversion, and we're gonna make sure that it kind of shocks not at the relaxation phase of your electrical impulse in the heart. Oh, that was a lot. Okay, so let's say you're doing your CPR, you come in, like your friend is on the floor, he's not breathing, right? What you do first is you call for help. It's not breathing, you call for help. You notice it's not breathing, you call for help. You come in, and then you're gonna check. As you're noticing it's not breathing, you're checking the pulse. If there's no pulse, you go there and start CPR. You start a CPR, which is 100 compressions, or 100 to 100 compressions per minute, at a depth of 2 inches, going in like 1, 2, 3, 4, and it can get really tiring. 30 compressions to 2 breaths, but you want to do 100 compressions per minute. And with this, if you're a nurse, you want to make sure that they have a patent airway, meaning they have a clear airway, they can breathe. So they might have to put an endotracheal tube or endotracheal airway, so that they can, they're able to breathe and you can give your breath. For children, it's 2 fingers, and yeah. I know that's pretty much it, really, and I know it's gonna be very confusing. This is like, I feel like in order to get to this, I feel like I should have talked about the heart. I feel like I'm gonna make a separate video, maybe with pictures, about like what a normal electrical impulse is like before the abnormal aspect happens. But on my next video, I'm gonna talk about what could go wrong with your valves, and what people or doctors can do about it. Thank you for watching my video. This was not an easy one to make, and yeah, I hope it wasn't like confusing, because damn, it's complicated. It's really complicated. Thank you for watching my videos. Peace, bye. See you in the next one.